All right. Good afternoon, everybody. Welcome to the webinar today. We're going to be talking about depression screening and treatment in primary care. This is part one of a two-part series, and the focus today is a physician overview of treatment guidelines. So welcome. Glad that you guys could be here today. We definitely want to hear from you. We've scheduled an hour and a half for this presentation, so we hope to get some questions from audience members. There are more than 80 people registered, and so we imagine we'll have a pretty good group on the webinar today. So we invite you to submit questions into the questions pane at any time during the presentation. We will organize the questions and address them all at the end, so in the last half hour or so of the presentation. One question that I can anticipate that we get every time is, yes, the webinar is being recorded, and a recording and the slides will be made available to all attendees and anyone who wanted to attend but couldn't be here by the end of the day today. You'll get an email to the email address you registered with a link to that recording when it's available. I'm just going to briefly introduce the Patient-Centered Primary Care Institute. The Institute is a partnership with the Oregon Health Authority and content experts all over the state of Oregon to get technical assistance, information, and resources out to primary care practices and those who work with primary care practices around the patient-centered primary care home or medical home model of care. We do webinars like this one. There's actually a library of more than 60 recorded webinars available on our website, a series of online learning modules about the patient-centered primary care home program. We partner content experts with practices for different projects. So I would encourage you to join our email list if you haven't already, so you are notified of learning opportunities like this in the future. I mentioned that we work very closely with the Oregon Health Authority Patient-Centered Primary Care Home, or PCPCH program. The PCPCH program is Oregon's model of recognizing primary care homes. It's defined by 6 core attributes, each with specific standards and measures that clinics attest to become recognized by the state. You can learn more about the PCPCH program at their website, which is on the bottom, primarycarehome.oregon.gov. We're also holding a webinar on October 3rd around the revised patient-centered primary care home standards. They're changing in 2017, so if that's of interest to you and your organization, you should sign up for that. Today, the purpose of the presentation is to review existing clinical practice guidelines for medication and non-medication treatment of depression, including the research that supports non-medication management of depression in primary care, and to provide information on addressing depression for specific populations as well. I'm very excited to be able to introduce our presenters and assure everyone that we're in really good hands today. Dr. Jonathan Betlinski is the Chief Medical Officer and Medical Director for OHSU's Project ECHO. He's also served in a variety of medical director and associate medical director roles in the community, most recently with Cascadia for both emergency services and their Plaza Clinic. He's been on faculty at OHSU since 2006. Where he remains a clinical associate professor of psychiatry. So glad to have him. We are also joined by Dr. Ann Wheeler, who's a clinical pharmacy manager at United Health Group and psychiatric pharmacy consultant for OHSU's Project ECHO. She's a highly trained board certified psychiatric pharmacist with a diverse background as a pharmacy director, clinician, and managed care specialist. She has over 15 years of experience working and teaching in the field of psychopharmacology, including experience working with Medicaid, managed Medicaid, and commercial health plans. So we're really pleased to have them here with us today, and I'm going to turn things over to our presenters.
All right, did we make it on?
You made it.
Yay! All right. Well, welcome everybody. Thank you so much for being here. I'm John Betlinski, as you might have guessed from looking at our pictures and recognizes us already, although we've changed our styles. I realized with some chagrin when I was looking at that picture just now that I very nearly wore the exact same shirt, tie, and jacket combination this morning, and what an embarrassing faux pas that would have been. We're going to spend the next about an hour really trying to review the latest stuff in how to screen for depression in the primary care setting, and then how to go about beginning to treat it in the primary care setting. So we hope that'll be useful. Fire off lots and lots of questions, and we're going to do our best to save the last half hour or so to work through questions and to cover stuff that we weren't smart enough to cover the first time. It is entirely possible that you will ask a question that neither Anne nor I knows the answer to, although given that Anne's here, I think it's pretty unlikely. I think we're covered and we're good there. So, without further ado, I'm going to launch. I'll spend the first bit talking about treating, or rather screening for depression, and we're going to look really at the prototypic depression, major depressive disorder, but we'll look at some other things as well. And then I'll spend some time talking about non-pharmacologic interventions and the evidence base behind those, and then I will hand it off to Anne to talk about the pharmacology of depression and how to go about starting that. All right. See if I can. There we go. Why even bother with depression, particularly in the primary care setting? After all, right, there's tons of folks like me out in the community who can very ably treat this stuff. Well, it turns out that the vast majority of Americans, about 70% actually, who seek depression treatment, actually do so from their primary care providers. Never mind that the majority of Americans who have a mental health condition don't bother to seek treatment for it or aren't able to seek treatment for it. But at least for depression, when people do seek treatment, they do it in the primary care setting. And as a result, most of the treatment, at least the pharmacology of depression, happens in a primary care setting. Once again, about 70%. Now, it turns out that there's no real difference in the overall severity level. One might be persuaded to think that the sickest folks go to see psychiatry and everyone else goes to see primary care, but studies simply do not bear that out. Folks are just as sick when they get treatment or when they seek treatment in the primary care setting. It turns out, of course, that the risk of depression is much higher in certain medical illnesses. I'm preaching to the choir on this one, but this is just a reminder that when you see folks with these physical diagnoses, you should be thinking about depression. So 1 out of 20 American adults, just a reminder, has depression. If we go to diabetes, that increases to 3 out of 20 people with diabetes. If somebody survived a stroke, we're now up to 8 out of 20. Cancer varies a little bit on the kind of cancer, but somewhere between 4 and 12 of people who have cancer also meet criteria for major depressive disorder, and for heart attack, it's even higher at 13. So let's talk about what is depression. Well, depression, the simplest definition is an abnormally low mood that interferes with your ability to fulfill major role obligations, to engage in meaningful relationships, or to do things that you enjoy, or as I like to think about it, to live, laugh, and love. Now, there are several types of depression. Of course, the classic is major depressive disorder, but DSM-5 lists several other kinds of depression as well. There's persistent depressive disorder, used to be known as dysthymic disorder back in the day. There's depression that's associated with bipolar disorder. There's substance-induced mood disorders. There's various depressions that are due to medical illnesses, and then the ever classic, yes, it's depression that interferes, but it doesn't match anything else, and so we call it depressive disorder, NOS. Let's look at major depressive disorder. Now, major depressive disorder, the diagnostic criteria really have not changed between DSM-4 and DSM-5. You have to have at least 5 of 9 symptoms present during the same 2-week period, and that has to represent a change from previous functioning. So this is a distinct change in mood that sticks around for at least 2 weeks, is present most of the day for more days than not during those 2 weeks. And there's one more catch. At least one of those 5 symptoms has to be either the first or the second. So a person must have either depressed mood or markedly diminished interest, so they lose interest in the things that are important to them. There are significant weight or appetite changes. There's sleep changes, so either you start sleeping too much or not enough. Psychomotor agitation or retardation. People get physically sped up or slowed down, and this isn't just them reporting it. In fact, that doesn't count. This has to be as observed by other people. And then there's fatigue or loss of energy. There's feelings of worthlessness or guilt. And this isn't just guilt about being sick. That might be understandable, but this is guilt that is greatly increased or disproportionate, perhaps, to what's going on. Diminished ability to think or concentrate, or indecisiveness. We forget about this one, but several of my mentors back during my training days said, if there isn't a cognitive impairment, it's not really major depressive disorder. So this one should be able to be picked up fairly easily. And then recurrent thoughts of death or suicidal thoughts. The way that the mnemonic that I learned many years ago is still a really helpful one. SIG-E CAPS. For depression, S is sleep changes, I, decreased interest, G, guilt or worthlessness, E, energy changes, C, concentration difficulties, A, appetite or weight changes, P is the psychomotor agitation or retardation, S is suicidal thoughts or increased thoughts of death, and then of course don't forget the depressed mood is one of the signs of depression as well. The question becomes, when do you screen for depression? Well, I'll be candid with you, nobody really agrees on this. The U.S. Preventive Services Task Force early this year came out with a recommendation to screen everybody. Every adult who comes into your practice ought to be screened for depression, that the only reason we weren't doing screening for depression before was because there wasn't adequate services, and why would we screen for something that we can't get treatment for? Well, I won't bother debating the logic of that. I appreciate that they want everybody to be screened. Certainly as soon as that was published, many experts weighed in and said, actually no, indicated screening is still better. I don't think you're wrong on either one on this, but at the very least, there are a handful of times when you absolutely should be screening for depression. One is if there's any family history or disposition towards depression. Two, any history of any psychiatric disorder, the vast majority of them increase your risk for depression. If somebody has 2 or more chronic diseases, if somebody has a stressful home or work environment, if they have a recent history of a major loss, think things like health, relationship, job, beloved pet, multiple vague symptoms, aches or pains, if they have a lot of physical stuff that just isn't penciling in or fitting neatly into a diagnostic box, worth screening for depression. And then loss of interest in sexual activity, and also probably worth at least screening all of your older adults. But again, if you and your clinic decide that you're going to take the step and screen everybody for depression, know that you're doing that with some good solid backing. You'll notice, by the way, on these slides that there's lots of links included on them, and we've done that because we want you to be able to go and look up more information on anything. So if we're pulling something from an article, if we're summarizing something or whatever else, we're giving you the whole link so that you can go read the whole article at some point if you wish. All right, how do you screen? Well, as you know, a lot of offices and a lot of practices are using the PHQ-2, which is simply asking for those first 2 things. Do you have any, during the last 2 weeks, have you had any loss of interest or any depressed mood? That is not a bad way to go. That's got about a 96% sensitivity if somebody answers yes to either one of those. The problem is it's lousy specificity. And so if all you do is that, and somebody screens positive, then you really have to follow it up with a PHQ-9 anyway. So my recommendation, and the recommendation of most of the treatment guidelines out there these days, is to go ahead and screen with a PHQ-9. Certainly, if all you have is a PHQ-2, do that. A PHQ-2 is easy to fit on a large questionnaire that's just doing lots of review of systems screening. But I would recommend doing a PHQ-9. I've given you a couple of links to PDFs that are suitable for handing out. This is just a reminder that a score of 10 or more on the PHQ-9. It has a sensitivity of 88% and a specificity of 88% in screening for major depressive disorder. If you got, and then you can see the scores there in terms of helping you be able to do that. So I like the PHQ-9 because it's simple, it's easy to use, you can hand it to somebody, have them fill it out, it's easy to score, and then, here's the bonus part, you don't have to switch screening tools when you're monitoring them in the long run. Every visit they come back in, you can have them fill out a PHQ-9, and you can find out whether the depression is getting better or worse. For adolescents, the PHQ-9 works just as well. Experts recommend a cutoff score of 11 instead of 10. Some folks have modified the PHQ-9 for adolescents. It's called the PHQ-9, or excuse me, the PHQ-A. It's got a few more questions on it that help you get a better understanding of the risk that somebody might be under, perhaps for self-harm or for suicide. And then there is even, I've given you a link for a really extended screening that you can use with adolescents if you're not comfortable with the basic. But please know that evidence-based wise, you're fine to use the PHQ-9 for both your adults and your adolescents. Just remember that adolescents need to score 1 point higher for you to have pretty reasonable certainty there. For older adults, I like the geriatric depression scale. The short form is sufficient. It's 15 simple yes or no questions, and a score of greater than 5 suggests depression with 92% sensitivity and 89% specificity. So that's a pretty reliable one. If you happen to be treating folks who have dementia, there's another great scale that's simple and easy to use. This is the Cornell scale for depression and dementia. It is 19 scaled questions, and a score of 12 or more indicates probable depression. The important thing to remember with the Cornell scale for depression and dementia is it is the scale that you hand to the loved one or the caregiver of the older adult with dementia. So while you're going over the GDS with an older adult, you can then hand the CSDD to whoever's come into the appointment with them, and then you get 2 valuable bits of information in the same. And both are reasonable tracking tools to use as well. Screening for depression is not hard, so I recommend using screening tools, and all of these are ones that you can simply hand to somebody and have them fill out, and then you can go over it with them. Let's change gears and talk about non-pharmacologic interventions. Just a reminder that the best evidence we have indicates that antidepressants are no better than placebo for mild to moderate depression. Anne's going to talk more about this in a minute, but I just wanted to give you permission to explore non-pharmacologic interventions first. Now, for severe depression, the evidence is pretty clear. Antidepressants absolutely make a difference. And for other cases like depression in pregnancy, yes, far better if the depression is not responding, far better to use medications than to try to keep going with non-pharmacologic interventions. Also a reminder that antidepressants may worsen bipolar disorder. The psychiatric community is divided on this one, but I would err on the side of safety if I were you. And if you're at all curious about whether somebody might have a bipolar disorder, or if they're indicating any sort of family history or any questions about it, I would screen them with an MDQ and at least have some comfort that they don't have this, because antidepressants may, in fact, make bipolar disorder much worse, perhaps for the rest of someone's life. Of course, antidepressants have drug-drug interactions. We're going to go over those again. And they can have some pretty aversive side effects. Overall, they are reasonably effective medications when we use them appropriately, and reasonably safe when we use them appropriately. The first thing you're going to want to do when somebody screens positive for depression is do a nice, thorough physical workup. There's all kinds of things that masquerade as depression, and indeed I occasionally have people show up in my office with a long history of depression that turns out to have one of these things that somehow got missed along the way. So you should always screen for hypothyroidism, for sleep disorders, do a thorough review of their medications and find out if it might be a side effect of something that they're on. Lots of nutritional deficiencies will show up as depression, the most common being vitamin B12, vitamin D, or iron deficiencies. I once had a patient show up in my clinic who met all of the clinical criteria for iron and B12 deficiencies, except he had normal-sized blood cells. And so nobody thought to dig any further, but it turns out, of course, that the vitamin B12 and the iron were canceling each other out, one driving blood cells smaller, the other driving them bigger, and so they looked normal. So it's worth digging around a bit to see what's going on. Exercise. Let's talk about physical exercise. There are 3 legs to the treatment of depression. One of them is exercise, one of them is medications, one of them is therapy. And exercise, at least in a couple of studies, just as effective as sertraline, which is the most commonly studied antidepressant, perhaps aside from fluoxetine. And so definitely recommend exercise. The high energy expenditure, the high intensity stuff is certainly best, but trust me on this, any exercise is better than no exercise. Does it mean starting with your patient just walking around the block, that's all they can do? Great, start with that. Exercise is going to have lots of other peripheral benefits. They're almost certainly going to get healthier in other ways. At the very least, whatever you're doing to treat the depression, you ought to include exercise as a part of that. Turns out regular exercise even protects against depression. Let's talk about sleep hygiene. Sleep hygiene is one of these things that for years, even in my training actually, just kind of got ignored. We didn't really pay much attention to it, but it turns out that loss of sleep is one cause of depression, let alone depression causing loss of sleep. Turns out that if you treat the insomnia with nothing but cognitive behavioral therapy, that's just a couple of simple techniques, that doubles the chances that somebody will successfully recover from their depression. So I highly recommend that. Start with sleep hygiene. The link at the bottom of the page there is a link to a wonderful handout that you can just print out and give to people. I do this very routinely. It includes such wonderful things as regular bed and awake times, not taking naps during the day, making sure your room is dark and quiet as possible. And my personal favorite, your bed is for two things, and you know what they are. So don't do anything else in your bed. Let's talk about light therapy. This has become increasingly popular in recent years. You can buy depression lights at just about any drug or department store. And good news, these things are effective. They seem to work for both seasonal affective disorder and for major depressive disorder. The rule of thumb, the more intense the light, the better it is. Ideally, you want people to use these things first thing in the morning. The problem with using them late at night is you then shut down your melatonin production, and now somebody's not sleeping very well. So have them use it in the morning. Ideally, first thing, turn on the light, hang out, sip a warm beverage, or perhaps put it in your bathroom so that when you're getting ready in the morning, it's there. Each of these things is different, so all I can advise you at this point is to follow the package instructions for how long you need to be exposed to the light. Certainly you as a clinician would want to keep tabs on hypomania because, again, light production could stimulate a hypomanic episode. But it's a low-risk, low-cost sort of option, and I commonly recommend these things for friends, family, and patients who move to places like Alaska during the winter. Whoops, went too far. Let's talk about psychotherapy. There are several types that are effective in acute depression, and the truth is probably most types of therapy are, but these are the ones that are best studied. Cognitive behavioral therapy, interpersonal therapy, and then various other kinds of behavioral therapies. We're going to talk about behavioral activation in a minute. For mild to moderate depression, these things are clearly, at least in terms of the available research, just about as effective as medications. Oregon's own Eric Turner at OHSU has studied both the positive and the negatives, and certainly when you factor in all the negative or neutral studies, the effective therapy is not as robust as it is when you only look at the positive studies. But again, just as effective as medications. The beneficial effects tend to be more prolonged than medications, which means if I treat your depression with therapy, the effect of that will last longer than if I treat you with medication and you stop the medication. And indeed, for people who are trying to get pregnant, this may be a better way to go. But again, keep in mind that depression creates more difficulties for a developing fetus's brain than does being on an antidepressant. Let's talk about behavioral activation. Behavioral activation is, in short, getting up off your backside and doing something. Turns out, the more you act like you're not depressed, the less depressed you're going to be, as a general rule. So I tell people to schedule their fun. If you wait until you feel like you're in the mood to do something, you're not going to do it because you're depressed. So schedule your fun and then make sure that you keep your own schedule. Also, schedule your responsibilities. For people who are really depressed, I sit down with them and we map out their entire day. This is when you're going to do this. This is the order you're going to do things in, so you can do that. I encourage people to sign up for volunteering, particularly volunteering with animals, because as it turns out, animals are helpful for depression as well. So volunteer at your local humane society, perhaps. Definitely encouraging people to engage in their spiritual or religious traditions. And finally, breaking things down into manageable chunks. So, for instance, if I'm depressed because I lost my job, I may not be able to apply for tons of jobs or find a job. That's a big chunk. But I can at least put out 5 resumes a day or 1 a day or whatever else. Let's talk about a brief scan of non-pharmacological interventions or other non-pharmacological interventions, at least when we get to treatment-resistant depression, and then I'll hand it over to Anne. There are 4 main therapies for severe major depressive disorder. So these are folks who are really sick and are not responding to 1 or 2 antidepressants. Then what do I do for them? Well, there's certainly electroconvulsive therapy. There's transcranial magnetic stimulation, vagal nerve stimulation, and then, of course, turns out good old cognitive behavioral therapy works really well for treatment-resistant depression as well. ECT might actually be what you want to try to refer people for right away. It is available here in the Portland area, and I know somewhat limited in other parts of the state, so I apologize if I'm giving you a resource that is not helpful here. But if somebody is depressed with psychotic features, if they have catatonia, if they are quite suicidal, if they're nutritionally compromised, or if they have some other sort of severe medical illness that is impeding their recovery, then ECT is, in some cases, the first thing we would try. It certainly works well also for those who it's worked well before, and some people simply prefer doing this as to taking medications. TMS is another way to go about this, whereas ECT requires you to have some sort of anesthesia and careful monitoring and often starts at 3 days a week. TMS usually starts somewhere closer to 5 days a week. You can do it in any outpatient clinic that's set up to do it. You send to the machine that zaps your brain with targeted magnetic pulses and stimulates superficial cortical neurons. It works. And it's also not at this point considered first-line treatment, so we're using it just for treatment-resistant depression. The evidence based on that is growing. Vagal nerve stimulation requires surgical implantation right just about where your collarbone is of a little device that looks a bit like a pacemaker and is wired into your vagal nerve and sends electrical pulses back up into your brain. Again, it works. It creates some weird things like throat tightening every time it pulses. But if nothing else is working, I've referred a couple of patients for vagal nerve stimulation with some reasonable success, and the evidence base is certainly there. In short, depression is common in primary care. It's astonishingly treatable. I recommend using the PHQ-9, as do most experts in the field, both for detecting and quantifying and monitoring depression. And just a reminder that the first steps are usually non-pharmacologic. With that, I'll hand it over to Dr. Hamer. Excuse me, Dr. Wheeler. I apologize.
I'll answer to either one. Thanks a lot, Jonathan. So if I have control of this, we're going to be talking about the pharmacologic interventions now as it relates to major depressive disorder in primary care. Let's see if I can advance. There we go. So as Jonathan said, really we look at using the antidepressant medications in severe major depressive disorder, and then in moderately severe or less severe depression, then it really becomes more of a shared decision-making opportunity with the patient before we would choose to use an antidepressant medication. Because really we would have non-pharmacologic preference if at all possible, because there are adverse effects and costs associated with using antidepressant medications. But it is recommended that we use antidepressant medications in severe major depressive disorders. And this chart outlines the PHQ-9 score that would be associated when the antidepressant is recommended. Also, combination of psychotherapy and antidepressant is often recommended first line, and we'll talk a little bit more about that. Here you can see what some of the advantages and disadvantages are of the different treatment modalities. So with psychotherapy, we know it's effective, we know it's safe. It doesn't have any physical side effects as we would expect to see with the antidepressant medications. The benefit of psychotherapy continues after therapy has been completed. We can't say the same thing for antidepressant medications. The disadvantage, possible increased number of visits that are necessary, the co-pays associated with those visits, is coverage available, that sort of a thing. With antidepressant medications, definitely important in the treatment of severe depression. It achieves greater improvement than psychotherapy in the first couple of months, after which the results are equivalent. And it is considered to be more effective than psychotherapy in the severely depressed. But the disadvantages are it's associated with side effects. Possibly in some patient populations it could increase suicidal ideation. And again, there's no long-term effect after the medication is discontinued. The combination is really where we want to shoot for. And if we look at the number of needed to treat for a positive outcome associated with each of these, it really makes sense to look at the combination between the cognitive behavioral therapy or other psychotherapies in addition to an antidepressant medication, because the two together are going to have a more positive impact than either alone. Of those antidepressants that are available, we generally lump them into these major classes. Now, we're not ignoring the TCAs and the monoamine oxidase inhibitors. Those are just older medications that we don't tend to use first line. The ones that we use more are the selective serotonin reuptake inhibitors, or the SSRIs, the serotonin norepinephrine reuptake inhibitors, or the SNRIs, and then a couple of others that we throw in this other bucket, both Wellbutrin and Remeron, which have different mechanisms of action, so we throw them in something that we lump as other. Under the SSRI category, we have a couple of brand name only medications. However, we have a lot of generic alternatives. So we have a number of low cost, very inexpensive alternatives that we can use within the SSRI class. And we have generic alternatives in the SNRI class as well. So how do the SSRIs work? Well, they selectively inhibit the reuptake of serotonin at the presynaptic neuronal membrane. How does that relate in terms of clinical efficacy? We can't really bridge that gap. We just know that it has to do with this theoretical pharmacologic mechanism. The SNRIs are, again, serotonin and norepinephrine reuptake inhibitors, and that is how they pharmacologically work. This is where Cymbalta, Effexor, Fetzima, and Prestique fit under this category, and again, we have a number of generic alternatives that we can look to. And then in the other category, we have Wellbutrin or bupropion, available as a generic. Bupropion is a weak inhibitor of dopamine, norepinephrine, and serotonin reuptake. So we are looking at all of the neurotransmitters that we would be concerned about. And then Remeron or mirtazapine has a very unique mechanism of action in that it increases central noradrenaline and serotonin activity by antagonizing central presynaptic alpha-2 adrenergic autoreceptors and heteroreceptors. So it really is in a class by itself. So the role of neurotransmitters in terms of its role on mood and anxiety, really we have a lot of interaction between the neurotransmitters, and this is a kind of a positive for us in that if a serotonin mechanism isn't achieving the control that we would like or achieving the outcome that we would desire, then we look at other neurotransmitters and the interaction that those might also have on mood and other symptoms associated with depression. So we have a lot of play here when it comes to the neurotransmitters and how antidepressants work. How do we choose the initial treatment? So we have information from the American Psychiatric Association that suggests that because they are comparably effective, both between the different brands that are available as well as the different classes of antidepressants are available, then we should base our choice on the following considerations. What are the anticipated side effects? What does the safety and tolerability profile look like? What is the patient's preference? What is the quantity and quality of clinical trial data? And then, not to be forgotten, the cost of these medications, because there are copays associated with these medications or out-of-pocket costs that are staggeringly different between those that are generically available and those that are brand. So we're going to talk about each of these. We'll look at the comparative effectiveness, talk about the side effects, drug interactions, patient preference, and cost. What does the evidence show? Well, we really know that the evidence demonstrates that the effectiveness and efficacy are similar between all second-generation antidepressants. They have roughly a 60% overall response rate. So we know that the clinical trial data demonstrates that between classes, between drugs, there really isn't a difference. So we need to rely on other factors when it comes to treatment selection, such as onset of action, differences in side effect profiles, and cost. So we'll dive into the side effects as kind of one of the primary things that we look at in terms of treatment selection, and one of the biggest things that we would want to consider are there any black box warnings. And yes, in fact, there are black box warnings associated with the antidepressant medications that say that patients treated with antidepressants should be observed for clinical worsening and suicidality, especially during the initial few months of a course of drug therapy. So this black box warning applies to all patients aged 25 years of age and younger, and really warns about the increased risk of suicidal ideation in these patients. I've provided some trial data that looked at the pooled analysis of placebo-controlled trials that suggests that for patients less than 18 years of age, there are 14 additional cases of suicidal ideation per 1,000 patients, or the number needed to harm there being 71. For patients aged 18 to 24, there were 5 additional cases of suicidal ideation per 1,000 patients for a number needed to harm of 200. So the greater message here is that, yes, this is something that we need to monitor for and pay attention to. However, we also need to recognize that untreated depression can also lead to suicidal ideation and behavior. Other common adverse effects associated with the drug classes that we've talked about. With the SNRIs, we're going to see quite a bit of GI intolerance, so nausea, vomiting. We also see dizziness, insomnia, agitation, headache, and sexual dysfunction. And sexual dysfunction is something that we're going to spend a few slides talking about. With bupropion, we see headache, we see agitation, we can see some weight loss. We certainly see some insomnia associated with that medication, particularly when it's initiated. And then with mirtazapine or Remeron, here we also see dizziness, some GI intolerance. We can see weight gain, and that's largely attributed to its antihistamine properties. We can also see drowsiness at lower doses. At higher doses, we tend to see more insomnia, and then we also see some dry mouth associated with this medication. I've listed in the next couple of slides some of the coping strategies for each of the adverse effects that are commonly associated with an antidepressant. So for instance, if somebody's experiencing nausea, that's typically going to go away with time, but in the meantime, they can take the medication with food, they can divide the dose, use sugarless hard candies, drink plenty of fluids, try antacids, that sort of a thing. For insomnia, which can be quite common, we would recommend taking the antidepressant in the morning, and some of the other sleep hygiene activities. So those are just listed there for you to review whenever it becomes a topic of interest. One of the things that I want to talk more about is the role of antidepressants in sexual dysfunction. So serotonin-enhancing antidepressants have been associated with diminished sexual desire, with delayed sexual arousal, and muted or absent orgasm. I've included a link there to an interesting article. It talks about the ability of antidepressants to jeopardize romantic love and marriage, and it's just an interesting Medscape article on that. What is the incidence? So this is based on clinical trial information that shows that the incidence can be as high as 28% with paroxetine, but in general they are all reporting some type of sexual dysfunction. The key here is understanding that this is the incidence that's reported from clinical trials, and these are all based on spontaneous report. So if you wait for a patient to respond and give you information about sexual dysfunction, this might be the incidence that you would expect. However, when we solicit information about sexual dysfunction, the incidence and the prevalence is actually quite a bit higher. The pivotal trial, the STAR*D trial, we'll talk some more about that when we talk about treatment selection and treatment progression. But in their findings, they found that about 54% of those in that study had decreased libido. 36% had difficulty achieving orgasm, and 37% of the males that were included in the study had erectile dysfunction. A cross-sectional survey of new SSRI or SNRI users found that treatment-emergent sexual dysfunction occurs in approximately 50% of patients. So again, we don't want to wait for our patients to spontaneously report sexual dysfunction. This is something that we should be asking about because it's definitely going to be something that can impact treatment adherence. What is our general approach then to antidepressant-induced sexual dysfunction? Well, in general, we want to try to avoid the serotonergic antidepressants if this is going to be a problem or it has already been a problem. So unresponsive to an SSRI, or if the patient is troubled by the SSRI-induced sexual dysfunction, we would consider something more like bupropion because it's not a serotonergic antidepressant. Those who are on an SSRI who suffer from sexual dysfunction, we can try decreasing the dose to see if that makes a difference. We can try to wait for spontaneous remission, waiting for 2 to 8 weeks just to see if it will go away. We can try switching to a non-SSRI, which is probably the best alternative. But sometimes we have to balance the efficacy of the SSRI versus losing that efficacy and not having the adverse effect. We can try switching to a different SSRI that probably is not going to solve the problem. We can try using another drug to offset the adverse effects, such as addition of bupropion or a phosphodiesterase inhibitor. Again, probably not the best alternative to try to treat an adverse effect with an additional drug. And then drug holidays. This is something that people have tried to say, okay, over a long weekend, I'm going to stop taking the antidepressant to see if that makes an impact on the sexual dysfunction. And this will work with medications that have short half-lives. However, the risk that we run there is that then we could also induce withdrawal. So kind of a balancing act between having the efficacy from the medication, the sexual dysfunction, and trying to sort all of this out. So the key points around antidepressant-induced sexual dysfunction are that serotonergic antidepressant incidence can be as high as 50%, and some have actually reported up to 80%. So this is something that we need to ask patients about. The lowest level of sexual dysfunction occurs with non-serotonergic antidepressants. Patients should be routinely asked about sexual adverse effects because it can affect their adherence to therapy, and the best way to avoid it is to use non-serotonergic antidepressants from the start. Other adverse effects associated with antidepressants. There have been studies looking at the impact of antidepressants on weight gain. This was a great study that was published in 2014 that looked at the impact of different antidepressant and different antidepressant classes on weight gain, and they compared them to citalopram. So it was used as the reference antidepressant, and then did it cause more or less weight gain associated with the drug. And the only statistical significant difference that was identified was that nortriptyline, amitriptyline, and bupropion had less weight gain than did the SSRI citalopram. However, I would suggest that the doses that they were using of nortriptyline and amitriptyline were probably not at antidepressant doses. Again, this is a healthcare system study, and for the most part, people use TCAs at low dose to treat things like insomnia or headache and that sort of thing, and they're not at antidepressant doses. The QT interval warning, this is something that a lot of people continue to be concerned about with citalopram and potentially with escitalopram, but definitely citalopram has had the FDA issued warning in 2011 that there is a risk for QT prolongation at doses higher than 40 milligrams per day. Really, the risk is higher in specific patient groups, and this is where the advisory should be in effect, is for those that are at greatest risk. And those are those listed at the bottom. So we want to use caution in prescribing citalopram at doses higher than 20 milligrams in patients who may have increased levels of citalopram in the blood. So if they're greater than 60 years, hepatic impairment, they are a poor 2C19 metabolizer, if they are on concomitant 2C19 inhibitors. We want to use caution in patients with congenital long QT syndrome, with bradycardia, hypokalemia, or hypomagnesemia, with recent acute MI or uncompensated heart failure, and then additional clinical monitoring such as EKG is recommended for patients who take greater than 40 milligrams of citalopram a day. SSRI enzyme inhibition. So this is another reason why we might choose one medication over another. So we know that they're all equally effective, but when it comes to drug-drug interactions, we're definitely going to want to understand the enzyme inhibitions that are associated with these medications. So this is a table that identifies some of the isoenzyme inhibition that exists with the SSRIs, and then other notable enzyme modification that occurs with duloxetine. It is a moderate inhibitor of 2D6. Bupropion is a strong inhibitor of 2D6. St. John's wort, if we're using a supplement, is a 2C19 and a 3A4, 5, and 7 inducer. Brintellix, Fetzima, and Vibre don't appear to inhibit or induce isoenzymes. Caution there is, however, we have much less patient years data associated with those medications because they are the newest. So just something to be aware of. Biggest caution is with some of the older SSRIs like fluvoxamine and fluoxetine, where there might be some isoenzyme inhibition that would lead to drug-drug interactions. The next set of slides looks at some of those clinically relevant drug-drug interactions, because all the time we're receiving notification from the pharmacy that says there may be a drug interaction, so is this one I need to pay attention to or isn't it? And this chart will kind of give you an idea of those where monitoring is required versus definite do not combine versus this is something that we just watch and identify if there happens to be further adverse outcome associated with it. So this again is for your reference. Summary of drug interactions then. Citalopram and escitalopram appear to be the least likely of all of the SSRIs to cause cytochrome P450 drug interactions. So those would be some of the primary choices, particularly in the elderly or those who are taking a number of medications where we're concerned about drug interaction. Venlafaxine appears to be less likely than duloxetine to cause drug interactions, and bupropion, this is something that we need to remember, is that it is a potent 2D6 enzyme inhibitor and it can lower the seizure threshold, so that can have an impact on how we are treating our patients as well. Here is a comparison table that looks at the comparative benefits and the comparative adverse effects, and this comes from meta-analyses and comparative data of the newer antidepressants. So this is something that you can refer to later. It just extracts all of the more comparative information that's available. So similar efficacy between our newer drugs, onset of action. We may see a little sooner onset of action with mirtazapine than we do with the SSRIs, but the response rates between all of the medications are similar at 4 weeks of treatment. Remission rates are also similar. Efficacy does not differ in older adults. We know that we can use fluoxetine daily and fluoxetine weekly with comparable response and remission rates. And then on the other side, where we're comparing adverse effects, again, a lot of them are very similar, but we have seen that discontinuation rates are higher with SNRIs than they are with SSRIs. Withdrawal symptoms are higher with paroxetine and venlafaxine than other SSRIs, and we'll talk a little bit about what those withdrawal symptoms are. And then, again, sexual dysfunction. We see less sexual dysfunction with bupropion than we do with the other more serotonergic antidepressants. So bottom line, first-line treatment selection. For adults, we would choose escitalopram, fluoxetine, or sertraline, but really guidelines would say that none of them are a bad choice. You can, as long as there's rationale for choosing it, there's no really bad choice as a newer antidepressant chosen first line. With pregnancy or breastfeeding, we have the most data to support fluoxetine and sertraline, and similarly, we have the most data to support the use of escitalopram, fluoxetine, and sertraline in the adolescent patients. There's a little footnote there to say if we're treating adult patients who are elderly, we would want to use lower initial doses and slower titration than we would in the younger adult population. This chart, again, is another reference for you that talks about initial dosing, titration schedules, and the usual therapeutic dose range for the available newer antidepressants. So once we've chosen an antidepressant, how do we define the goal of treatment? Because we want to monitor. We want to identify when outcomes have been reached that are appropriate for using the antidepressant medications. And a lot of clinical trials use response as a goal of treatment, when really we should identify our goal of treatment as being remission. So response is defined as a clinically significant degree of depression symptom reduction following treatment initiation. Response really has to only be met for 3 consecutive weeks, but really what we're looking at is remission, and this is the virtual absence of depressive symptoms for 3 consecutive weeks must pass, during which each week is characterized by the virtual absence of depressive symptoms before we ascribe remission to the patient. And then remission ends with either relapse or recovery, and our ultimate goal is recovery, so that the patient lives without the burden of depression. So in order to achieve our goal of remission, then we choose our medication, we choose our initial therapy, and we hope that it works. But what we really see in our sequence treatment alternatives to relieve depression, or STAR-D study, was that with our first selection, our monotherapy selection, we see only about a 30% remission rate. And of those 30%, then 33.5% of those relapse. So it really goes to show how we are going to have to choose our first treatment selection well. We need to use our first treatment selection at an adequate dose for an adequate period of time before we try switching. And when we do switch, there is some rationale as to how and what we switch to. So a second level of treatment in the progression would be to switch to a different SSRI, to a bupropion SR or venlafaxine XR, or we could try augmenting the first SSRI with bupropion. And so again, another reference slide for you just to understand some of the switching or augmentation strategies that are associated with progressing through our treatment selection in antidepressant therapy. The first treatment selection definitely has the greatest impact. So again, this is something we want to choose our selection well. We want to use it adequately at the right dose and for a long enough period of time. So what is that period of time? Well, we really need to give adequate time for the neurotransmitters and the receptors to adjust. And this can take up to 12 to 14 weeks. So before we abandon therapy, we want to give it an adequate trial. Now, if somebody's having intolerable side effects, we act sooner. If we're not seeing any improvement at all after a few weeks of treatment, we might act sooner and increase the dose. However, we just don't want to abandon what might otherwise be a good trial of an antidepressant medication. If we do end up needing to switch to other medications, this is a table that will give you more information about how to switch. Sometimes we can do a direct switch and it's safe. Sometimes we need to recommend a cross taper, and sometimes we have to have an entire washout period. So generally when we think washout period, we think monoamine oxidase inhibitors. With the rest of them, we generally can get by with a cross taper or a direct switch. And then I've also listed in the next couple of slides some augmentation strategies, those medications that have more evidence than others in terms of what can we add to an antidepressant in order to perhaps make it more effective. Some of the better studied ones are included on this slide, and they include lithium and T3. These are well studied, generally easy to tolerate, although with lithium we need to consider the adverse effects, potential toxicity, and need for serum monitoring that might be associated with it. But T3 is definitely an easy addition to antidepressants. And some have found it actually helps speed up the antidepressant efficacy when T3 is added to antidepressants from the get-go. And this even is beneficial in euthyroid patients. Other augmentation strategies, we can add bupropion, buspirone, and mirtazapine. STAR-D found similar results compared to buspirone when we add bupropion. With mirtazapine, it's been studied as an addition compared to the addition of monoamine oxidase inhibitor, or compared to the monotherapy use of monoamine oxidase inhibitor tranylcypromine. Low efficacy with both agents. Mirtazapine was better tolerated than the MAOI. But this was done later in the sequence of treatment selection. Additional augmentation strategies, we can consider adding mood stabilizers such as topiramate. There was one small placebo-controlled study that showed significant improvement in depression compared to placebo. With lamotrigine, augmentation studies have generally not been positive. And with valproic acid, again, small studies, not a lot of data to support the use of an addition of a mood stabilizer unless this is a patient who has risk for bipolar disorder or bipolar depression. Then we would treat it differently. Evidence to support the use of stimulants. Studies of stimulant medication for antidepressant augmentation have generally been pretty negative, and this includes studies of methylphenidate, modafinil, and atomoxetine. So despite their initial euphorogenic effect, generally we're not going to see positive result from the addition of a stimulant to an antidepressant medication. With Pendolol, positive open-label trials and a small placebo-controlled trial have occurred. Results from a larger study have been negative, however, and then with the addition of hormone therapy, there have been mixed results. Atypical antipsychotics, this is something we should definitely talk about because we all see the commercials associated with the newer atypical antipsychotic medications, and shouldn't we all be on an atypical in order to treat our mood deficiencies? The answer is hopefully not. The effectiveness needs to be balanced with the high rate of adverse effects that are associated with these medications. The few long-term efficacy and safety studies that are out there, we don't have any that directly compare them to other augmentation agents. Overall, the odds ratio for response when compared to placebo is 1.69. The odds ratio for remission is 2.00. And the odds ratio for discontinuation due to adverse effects is 3.91. So we have some information with aripiprazole that shows improved response and remission rates compared to placebo with an average dose of 11 to 12 milligrams per day. Some trials only showed improvement in clinician-rated scales and not in patient-rated scales. And there is a high rate of akathisia associated with this medication in the treatment of depression. With Seroquel or quetiapine XR, significant response rate compared to placebo. However, we are also seeing significant adverse effects, including sedation and weight gain. With olanzapine or Zyprexa, there are 2 positive and 3 negative trials when compared to placebo, when we look at the combination of olanzapine and fluoxetine, and weight gain and metabolic abnormality is a significant issue. With risperidone or Risperdal, there are 2 placebo-controlled trials that show advantage over placebo, and there's one with more negative results. A long-term augmentation study showed no difference from placebo in time to relapse or in relapse rates. And with the new medication, Rexulti or brexpiprazole, there are 2 6-week trials. Only the 2 milligram dose is superior to placebo in one of the studies that was done. These others are more under investigation, so we will skip past those for now. When we do decide to taper and discontinue an antidepressant, it is important that the doses decrease slowly, and that is because of antidepressant withdrawal. So there isn't a serotonin discontinuation syndrome that's associated with these medications, and we can associate with this acronym FINISH. So we finish the antidepressant, now we can expect, if we don't taper, to see flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances, and hyperarousal. For some, this is mistaken as a recurrence of symptoms of either the anxiety or depression that it was being used to treat. And in actuality, it is the withdrawal syndrome. So how can we differentiate that? So antidepressant withdrawal syndrome is characterized by the time-locked emergence of new defined and quantifiable signs and symptoms which develop upon cessation or reduction of an antidepressant that has been taken for more than a few weeks. The symptoms typically start within 24 to 72 hours after the last antidepressant dose and peak within a week of being off of therapy. Typically, they will resolve within 1 to 3 weeks, but they are severe and disabling in about 5% of the patient population. So it's best to try to avoid withdrawal if at all possible. We do this by tapering the dose more slowly to decrease the symptoms. If we restart the antidepressant, if somebody is miserable with the withdrawal symptoms, we can restart the antidepressant at the last dose and the symptoms should go away. And then slower tapers may be necessary in those patients. Those that are less likely to cause antidepressant withdrawal are those with a longer half-life. So fluoxetine with an 84-hour half-life will taper itself out of the body quite well. Those that are likely to cause antidepressant withdrawal are sertraline, citalopram, escitalopram, duloxetine, and vilazodone, and those that are most likely to cause it are very activating and shorter-acting products like venlafaxine, desvenlafaxine, and paroxetine. I've got some over-the-counter alternatives listed and some of the things to watch out for. However, I'm not a huge fan of some of the supplements, although there is quite a bit of study that's been done with St. John's wort. My caveat and recommendation is that if somebody is going to use an over-the-counter product or supplement, that they look for one with high quality standards because these are not regulated by the FDA. I think Jonathan is saying something, but I can't hear him.
Yeah, you would think I would know how to work this thing. I was just going to say, yeah, definitely do the sunblock thing. If you're going to do St. John's wort, it will give you a really strange blotchy tan. So definitely warn folks about that.
Yeah, thank you for that. And one of the things that I also like to point out, because I do think that cost is a factor when it comes to treatment selection, is that there's a huge variation between some of the newer products and some of the older products that are out there. This was a good RX.com price comparison that I did, and some of these are going to vary depending upon the pharmacy and the region. However, some of these have a closer to $300 a month price tag compared to others that are a $5 product. Or even if someone is able to, and you can see where the dollar signs exist, if they're able to get them off the Walmart drug list, they could get $4 and $10 generics. And what that means is for $4, they'll get their citalopram for a month. If they want to go with $10, they'll get a 90-day supply. And if they can cut tablets in half, they can actually get a 180-day supply for only $10. So some of these make a lot of sense to choose the lower cost alternative, particularly when somebody is having to pay out of pocket. And oftentimes, these $4 and $10 generics are less than members' copay.
And Fred Meyers and Target do cheaper lists like that as well.
Yes, very true. So in summary, the best chance for success, which we would define as remission, may occur with a first trial. So we want to use an adequate dose for an adequate duration, and really any of the newer antidepressants are going to be a reasonable first-line choice. We can make an excuse for any of them that we might pick. However, we want to consider what some of the adverse effects might be associated with that first trial and see if somebody is going to be adherent to that therapy. Again, the goal of treatment is remission. We have good data to talk about the sequential approach to pharmacologic treatment. We favor monotherapy whenever possible. We've talked about some of the switching and augmentation strategies should that be necessary. And most antidepressants are going to require tapering in order to avoid withdrawal once we're done with therapy.
All right.
There's...
I just wanted to check in with you very briefly. I'm so sorry, and I steamrolled over you, and that's incredibly rude, but I'm bragging, actually, very briefly about additional resources that are available to you should you want some help when confronted with folks in your practice who have difficult mental health challenges. One of those is OHSU Echo. You noticed in our intros that both Ann and I work for that, but there's an adult and a child module giving you the link there so you can learn more about those. Opal K is a call-in line. If you have a kid in your practice that you want to get some help with, you can call Opal K. There's information on that as well. And then certainly investigate in your local communities. The impact model from the University of Washington is spreading around the country. And increasingly available, and you may be able to get in on that. It uses a single psychiatrist or psych nurse to support multiple primary care practices by doing case management remotely, as opposed to seeing patients directly very often. All right, and last thoughts?
I'm open to questions.
Awesome. Thank you to both of you. You got a ton of information into that hour. We really appreciate it. Folks, again, who have questions can type them into the questions pane in the GoToWebinar control panel. For the few people who maybe trickled in late, a recording and a copy of the slides are going to be made available. They'll be posted by the end of today and then emailed out to everyone who registered, as well as and attended, as well as those who registered and couldn't be here. One question that I have is about engaging, support staff and other clinic team members in both the screening process and then the ongoing management process, and what thoughts you have about that. I know we're going to be having another webinar on workflow on this very subject, actually, in October. So I would encourage people to come back for that. But what are your thoughts about that?
I'm going to defer to Anne first, and then I'll chime in.
Yeah, so involving other staff, I think that there are great screening tools, and Jonathan talked about the PHQ-9. I think that anybody can help deliver that tool. I think it's an important way to screen patients, and anybody can be involved in that screening process. We talked about the specificity and the sensitivity of doing the PHQ-2. I think there's a good reason to ask some of those questions and then dive a little bit deeper when the clinician can actually sit down with the patient and do a full PHQ-9. But, I think that there is reason to get other people involved in care, just because I think this is something that tends to be under-recognized and something that we can all be helpful to work toward.
Yeah, I think the beautiful thing with the screening tool is that you can, in your practice, decide who the best person is to administer that and review that. It doesn't take a highly trained clinician to review the PHQ-9 with somebody, but it does take a clinician to decide what to do with that. And so you can decide whoever it is that rooms the people in your clinic is the person who makes sure that questionnaire gets completed, either by reminding somebody to complete it or by reviewing and saying, oh, well, here's your score, and I'm going to make sure that Dr. Smith or your nurse practitioner or whoever is coming into the room next is going to want to talk with you about this. And you can do that whether that's follow-ups or other. In other words, if you find yourself in a particularly busy practice and not able to have in-depth conversations with folks, you can delegate those conversations to other people. I would encourage you, where possible, to have those conversations yourself, but I think at least as far as the screening and completing the screening is concerned, absolutely do that. The impact model has a bit more to say about this, in that in addition to having a psychiatric LNP who sort of is keeping an eye on multiple practices and relying on the primary care providers to do the prescribing, it relies on nursing case managers or care coordinators to really keep track of, say, a panel of 50 folks who are depressed in a primary care practice. And so the nursing care managers who checks in on them regularly and in between visits with the primary care provider. So again, if somebody's really depressed, I don't think you necessarily, if you start them on an antidepressant, I don't think that you have to be the one to see them back next week to see how it's going. I think you can delegate that to another member of the staff team to call the person and check in and find out how it's going and find out whether they need to urgently come back into clinic or whether things are going as they would be expected, and they can come see you at the regularly scheduled visit next month.
Excellent. And there were some questions in the registration process, and we get them often on webinars, about getting more honest information from patients. But maybe we could rephrase that to say, how do you have these kinds of conversations? Or for people maybe who are newer to diving deep with this in their practice, what suggestions would you have about honest communication with patients about what could be a sensitive topic?
The infamous TV show House MD, of course. Dr. House is famous for saying everybody lies. And he's probably true about that, but I don't think everybody lies deliberately. I think most of us are inaccurate reporters. I've had a few embarrassing slips along the way with my own healthcare providers when they say, did this happen? I'm like, what? No, that never happened. And then, you know, I walk out of the office 10 minutes later and I'm like, oh, wait, yeah, actually didn't say that right. So I think the way to do this is to make this, to normalize the conversation as much as possible, right? So lots of people have this challenge. So, so you've been feeling pretty sad lately. It turns out a fair bit of people who tell me they've been feeling sad also tell me they find themselves wishing they could just, you know, take a long vacation or take a bunch of sick days. And I'm wondering if that's happened for you. Oh, it has. Oh, okay. And oftentimes when people tell me that, they also tell me that, you know, they've had some random thoughts about, well, gee, you know, at least if I died, I wouldn't have to deal with this. And I'm wondering if that's happened for you. Oh, that's happened for you. Oh, okay. And sometimes when people tell me that, they'll tell me that they've actually found themselves thinking of ways that that could happen. And I'm wondering if that's happened for you. So rather than coming straight out and saying, have you been having thoughts of killing yourself, I think it's really great if you demonstrate more interest in somebody, and you're going to learn more about them if you walk them along like that and normalize it. And also, I mean, depression is one of those things in our culture that we still sort of think is some sort of a character weakness. And if you were just living right, you wouldn't have these problems. So anything we can do to reassure people that they are not crazy, that's wonderful. That is the #1 reason why people don't seek treatment, and that's the #1 reason why they won't be completely honest with you about their mental health symptoms, because they're afraid you're going to say they're crazy. And nobody wants to be told they're crazy. So anything we can do to say, oh, well, that's part and parcel with what happens in depression. Let's talk about what we can do with that. Then I'm a huge fan of, when it comes to choosing medications, for instance, asking somebody, if there were a perfect medication, what would it do for you? Because that's going to help me then be able to wade through all of those wonderful side effect profiles that Anne just reminded us about and try to choose the one that's going to give us the best chance of success. Odds are the thing that works the best for somebody's depression is whatever they believe is going to work the best. And so I try to get them to have as much input as possible into that, which again puts power back in their lap and it sort of normalizes what's going on for them and gives them a chance to take control. Anne, what am I missing?
Yeah, the only other thing that I would add to that is the fact that we need to be culturally aware that there is differences in how different cultures may approach depression. So we might see that there's more psychosomatic symptoms pop up with a certain patient population than others, and just being more aware that we need to dive a little deeper, ask questions a little bit differently depending upon the patient that we're seeing.
Excellent. I think that's a good segue into the next couple of questions. I know you touched on this throughout the presentation, but a fair number of folks who tune in to our webinars are in pediatric practices, so they're working with kids and adolescents. If you had to just say, what your 3 takeaways are around this issue when you're thinking about adolescents and then also older adults, what would those be?
Wow, 3 things for working with adolescents. I'm going to break those into 2 separate things. So, Anne, let's talk adolescents first, and then we'll come back and talk older adults. 3 things with adolescents. Number 1, adolescents in this state do have the right to seek mental health treatment without adult consent, but you do have to notify the adult. So I think the #1 thing that I think about when working with adolescents is all of those consent issues. If you're unsure, just do a quick search, remind yourself what the codes are and what the ages are and what you need to do to make sure that you're in the right. Especially if somebody's in foster care, it gets particularly complicated because you got to get someone else to sign off on the consent. So that's #1. Number 2, we all got very scared a few years ago when the FDA came out with a black box warning saying these medications increase suicide in people under a certain age. But let's not forget that untreated depression also increases risk of suicide. So I wouldn't let fear hold me back from treating, but I would make sure that I'm monitoring regularly and carefully and having those conversations, those candid conversations with a kid and with the whatever adult is present in their life. The third thing that I would say is that kids, the social dynamics can be challenging, right? Most of us in our lives just want to be normal. I'm very grateful to be in my now 5th decade of life when I'm just slightly less worried about what other people think. It's not much, but it's noticeable, and I'm grateful for that, and I'm hoping it continues. But particularly during adolescence, the need to be normal and not be singled out and somehow be different is incredibly important. And so being able to talk with kids about everything that's going on in their life, as our kids here at Cascadia have reminded us, our adolescents, you don't have to be into the stuff that we're into, but you do have to be interested in us. So make sure that you're interested in your adolescents at a level far more than just your symptoms of depression and how's this pill working, but be curious about whatever else is going on in their life, because that's where you're going to glean clues about what's really going on and how you can be helpful.
And I'll just add to that, and I'll say recognize the limitations of medications that it can't solve for problems such as trauma, so on and so forth. And then my other big point that I want to get across is that monotherapy. We see way too many issues regarding polypharmacy, and we start something, it's not working well enough, so we add something else to it. And if at all possible, particularly in our young, sensitive patients, if we can use low-dose monotherapy and really have good rationale for choosing that medication, and then follow up with monitoring and outcome that we're keeping track of.
For adults, I would say absolutely the number one thing, you got to screen all of your older adults for depression. You just gotta. It sneaks up. The further we go in life, the more prominent loss features in our lives, and that is one of the biggest risk factors for depression. So you got to do that. The number two thing with adults is you got to screen for substance use. You just gotta. Alcoholism, actually rates of alcoholism go up later in life, and alcoholism will look like depression, and you will feel very sheepish when you discover that you've been treating somebody's alcohol use with an antidepressant. I say that because I once did that. Turns out she was drinking a bottle of wine every evening to try to get to sleep. And then three, pay attention to the side effects, particularly the anticholinergic side effects. The further along we get in life, the more sensitive we are to the anticholinergic effects of medications, and you can make somebody look like they have dementia just by putting them on an antidepressant, because their brain won't be able to process thoughts as well. So pay special attention to side effects. The fourth, I know I only get three, but the fourth thing I would say is to remember that depression often masquerades as dementia. Indeed, there's good studies showing, looking at people who screened positive for dementia but screened negative for depression, treated with antidepressants, and the dementia magically got better. So when somebody begins to show signs of dementia, thoroughly screen them for depression and consider treating that before you sign off and say that somebody has dementia and it ain't getting better.
Completely agree, and the one thing that I'm going to add to that is that treating depression in people with comorbid medical illness is often going to make the comorbid medical illness improve as well. So a good reason to screen, a good reason to treat.
Excellent. Thanks to both of you. I think that's it. If there are any last questions, folks have about 30 seconds to write them into the control panel. And then we'll go ahead and wrap up for the day. I just want to remind everybody there is a post-webinar survey that you can fill out and let us know what you thought of the webinar today and any remaining questions that you have. And then there's information about this part 2, workflow and engaging the clinical team on Wednesday, October 5th from 8 to 9 a.m. You can register on our website to sign up for that webinar as well. I want to thank our presenters today for joining us and for bravely facing the webcam. Very appreciated. And I hope everybody enjoys the rest of their day.
All right, get out in the sunshine. It's good for depression.
Thank you.